Tongue ties can be some of the most confusing things clinically. We've got some doctors and dentists who don't believe in tongue ties at all, think it's overdiagnosed. We've got some who are just all the time. They see it everywhere, it's overt. And somewhere in between are a bunch of clinicians and myofunctional therapists who really just don't know what the parameters are or how to make a clinical assessment of whether something is a tie and needs to be managed surgically, or if there is a non surgical approach that can be taken. And stick with me today, and I promise you, we are going to touch on all of those things to really fine tune a clinical framework because that is what we need most of all. All right. Let me grab my slide here. There we go. Welcome, welcome. It is always a pleasure to be here with you. If this is your first time, I'm Carice Laguerre. I'm your Myo best friend. I am here with you on a regular basis to talk all things myofunctional therapy, all of the time. That's just all we talk about. I've got over 100 hours of education and lectures that I was about to merge those words, education and lectures. So lectures, I don't know what that was, but we've got over 100 hours of education, and all of that is all on LinkedIn and or YouTube. So wherever you're watching me now, give me a hi, hello in the chat. And then from the hi, hello, just subscribe, like, connect, share, continue to comment. That's how we grow. That's how we keep this going. But I'm not going to hold you too long in this intro. I will have three, not one, not two, but three different quotes from Neil deGrasse Tyson in this lecture. I am a big fan of learning, and there's nothing that I value more than what I can learn, one from others, but two, really just myself. And as I listen more and learn more and get more, I don't know, worldly, I guess, the more I know that I don't know. And that's how you know you're really learning, because you understand that there's a limit to the things you know and understand. I found some quotes that I thought were really, really relevant to match in with today. People value what they think is true more than what is true. And nothing could be more relevant for something that is so subjective, like a tongue tie. Yes, I said subjective. I know ankylosing is a thing. I know that it is more often than not defined by structural appearance and what is there. However, I gotta tell you that there's so much misconception, there's so much pushback on the field that you can't help but notice, and you have to keep it forward of mind that not everybody's on the same page about this thing. It can't be a thing if there's no standards around it. It can't be a thing if it's not something that we've really established universal criteria, research, and support for. So there's going to be some really, really deep defined things. And what I know to be true is that everybody will push back on something that you believe is really pushing on something that is very, very deep within you. So if you have had a tongue tie release, if you have helped others with tongue tie releases, if you feel guilty about not telling somebody that they had a tongue tie release, you might take certain things I'm going to say today very, very personal. Your brain might shut it off. You might, whatever, but I'm going to implore you to push back against that thought. You will expand as you come out of, any sort of thoughts that this is like a personal thing, or this is something that, I'm talking about that is like an attack on anyone. It's not. I want us to have a standard of clarity, and we can't learn and grow unless we're all on the same page. And my page is typically that tongue tie can be considered a modern medical scam. I have already done this lecture. Okay, this lecture, there you go. This lecture is one that I will link at the end. to this very video. So you can either skip to the end if you need that background, but I've already done my yelling. I've already done my hooting and hollering. I will not deja vu you with that about why it is overdiagnosed, in my opinion, why there are so many misunderstandings today. We are walking away from that type of energy and walking into a more positive space where, you don't need to get it twisted, but we are going to talk about my protocols, because it's not that I don't believe in tongue ties. It's not that I think that, frenums can be stretched away, or, there are people who are doing tongue tie releases and they're completely 100% unnecessary. No, 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 no. I believe in tongue ties. Tongue ties are a thing. Frenums do exist. We all have them. Some are functionally restrictive. But there's a difference between functionally restrictive and structurally restrictive. These two things are completely different. And so we're going to break that down today. But I need a clear understanding, okay? This is not about why I think it's a scam. There's a whole other video about that. This is about my protocols and how we can move forward once we've determined, okay, this is how we treatment plan for this. This is how we're going to move forward with this. This is how we are now going to be looking at it from this new lens and vision. Okay. Keeping in mind always that nothing is universal, especially in myofunctional therapy and in airway. Everybody's doing their own thing. There is no universal standards or protocols. I don't care who you follow. I don't care who's doing research. I don't care who's a leader in the field. None of it is universal. There is not enough true validated research that we can have so that we really get it down. And I think what you have to remember is that a lot of other fields came about at a time that was different. We wouldn't have cranial sacral therapy, or maybe we would, but it probably wouldn't be as big as it is today. Or I don't know, relatively, it's definitely bigger than myofunctional therapy, but what isn't? But it is something that came about because there was an osteopath who felt that everybody should be doing osteopathy. I'm going to teach people this. And then decided to just distribute that information. And there blossoms cranial sacral therapy. But I don't think that that would work today. I think there would be a lot of pushback. There would probably be a lot of legal ramifications of taking all of your osteopathic information and just distributing it to people. I mean, it's really, really a different time that myofunctional therapy is trying to thrive in, because it's so far behind everything else. So when we keep that in mind, you can kind of understand why, one, channels like this exist. And I say channels with an S as if I'm not like one of the few that's actually sharing intimate, personal, and like very, very thorough information about my protocols, my treatment planning, what it is that is new, and how to make myo fun, engaging, effective, yada, yada, yada. We have to share this information. If we don't share this information, we can't get on the same page to become validated and become more real as a field. We have to have access to this information. And so having it behind some closed wall, or having it only exclusively at certain events, or, oh, we're only going to release this information here, there, and everywhere, so that everybody has to run around and chase the people who are leaders in the field to find out research and protocols is kind of wild. It's very, very wild for a field that's not where it should be. And for that reason alone, I just need you to keep in mind that there is nothing universal. We're not there yet. So when you're hearing my protocols, you're knowing that this is my protocols. Yes, you do something different. Every single therapist does something different. It's okay as long as you're effective. Okay. Secondarily, I don't believe in cookie cutter programs. Function is a very personal thing. I treatment plan individually for every single person. And I think nobody really believes that, or at least most people, I think, are a little bit skeptical about it. They're like, myofunctional therapy, everything I've heard about it online, it just sounds pretty like cookie cutter. Like, how many exercises can there possibly be? Well, that's great because we go well beyond exercises in my programs. But it is something where it's so personal that once you start seeing it, and like if you have multiple people in a family and they see that their programs or their exercises or where they're at is different from each other, like, oh wow, this really is custom for me. Oh wow, there are blocks that I'm hitting that my sibling, my child, my spouse is not. And these are things that, you have to custom treatment plan because everybody's different, right? So there's going to be that element to this too, where we're going to be talking about treatment planning because you have to individualize your treatment planning. So keeping all of that in mind, we're not talking about how it's a scam because it is. We're not talking about universal protocols or like everybody must do this. We're talking about just my protocols. And function is very, very personal. So you've got to keep that hat on, that clinical mind. Because if you are a therapist, you should be able to therapeutically determine what's going on. And so you have to be able to look from that critical eye. And with that said, what exactly makes up a tongue tie? Now, a tongue tie, in my humble opinion, it's a triad. There are three different things that have to come together in order for it to be a tongue tie. That is right. I don't care what it looks like. You could be tied straight to the tip of the tongue. You can't do anything with it. Your tongue is down and there is nothing that you can mobilize. If you have not all three things on our little triangle here, it's not a tongue tie. You just have a tongue and a frenum. We all have a frenum. Okay, might be a very short, very visually restrictive, but it wouldn't be functionally restrictive if you don't have all three. And that's really important to note. All right. Now, very obviously, structure is going to be part of it. What it looks like, of course, has to be a part of it. But there are plenty of people who don't have restrictive frenums, but do have two other points on the triad, on the triangle, or like this triad of things that I want all of us to be able to be aware of and look at. So structure is a part of it, but it is 1/3 of it. It's got to be all three, okay? Function is going to be the next one. How do you know if something is functionally restrictive if you're not checking function? And function, we're going to get into this very soon, but function is not simply or merely when the tongue elevates or when it's in suction, because those are our classification systems. Elevate the tongue, and you're either measuring from the tip to the frenum attachment site, or you're getting them to elevate and you're measuring interincisal, or you're measuring in the suction. Like, you're measuring somewhere that is just a limited view of function. The tongue has a lot of different ways it moves. It is a muscular hydrostat. You need to be able to understand that and all of the functional capabilities of the tongue to be able to determine function. If you cannot, you should not be determining that something is a tongue tie. Does that mean that you don't diagnose? No, it means that you absolutely refer out and collaborate with somebody who understands that aspect of it. Likewise, if you're a myofunctional therapist and you're not 100% sure on structure, you might want to refer out and collaborate. Put your notes together on function with their notes together on structure, and together you collaborate and are able to determine between those 2 points of the triad. The last one is the most important. It's the symptoms. And that is often what is lagging, or what is lacking, I should say, when we're looking at structure and how structure really does impact the person. There are people who've been walking around their whole lives, tongue as it is, and it could be the most restrictive tie you've seen in quite a very long time. You mentioned that they have a tongue tied to them. They're like, what? What are you talking about? Like, I'm fine. I don't have any problems. I've never had speech therapy. I eat great. I love all types of foods, all types of textures. I've never been picky. My mom breastfed me until I was 18. Like, whatever. They tell you all types of things. And you're like, well, that doesn't really match up with what I see, but this could cause a problem down the line. And so maybe you might want to consider getting it released. Based on what? Based on what? Because you saw something that looks like structure without ever assessing their function, because they might have more functional mobility than you could have ever imagined. I do so many consultations because my consultation is free. I do so many consultations. And in my consultations, whenever somebody sent, like, oh, yeah, my provider told me that I had a tongue tie, my pediatrician told me my kid had a tongue tie, my dentist said that the kid had a tongue tie, my periodontist says I have a tongue tie. There's so many people that refer for myo and tell them that they have a tongue tie and to come for prep for release. And as we start to talk, and I think I'm jumping a little bit ahead of myself, but just love me and follow me, all right? 'Cause I love you. That's why I'm giving you this little tangent. But as I'm talking to them and I'm not hearing red flags of dysfunction, and I'm asking them very pointed questions about congestion, about breathing, about sleep, about digestion, about their dental history. I'm asking very pointed questions and I'm getting very few, if any, red flags. I'm like, what makes you want to release this tongue tie? My doctor said that I need to, that it could cause a problem or it might be like part of something. Okay. And if you're not need, that might have a part of your impact in your dating life too. I mean, like what? We can't have a crystal ball and be like, oh, well, maybe it'll cause a problem in the future. You don't have a problem right now. You don't have a problem right now. I can't predict whether or not in 10 years you're going to have a problem. And if you do come across a problem in 10 years, maybe we cross that bridge then. But for right now, you're good. I'm not seeing a bunch of red flags. I wouldn't call it a tongue tie. If you do have some issues that you want to resolve and you feel like your oral rest posture isn't how you want it to be and you want to optimize that, let's talk. But we're never going to get back into the topic of release, because what are we releasing? Why are we cutting tissue in your mouth? You got to have all three. So it can't just look like a tie. It can't just be limited in one or two functional aspects that everybody looks at and wants to determine that, oh, yes, that is the penultimate description of how we assess function. And it can't all be symptom based, because there's a lot of people with a lot of symptoms and a lot of dysfunction that structurally, I'm like, that it doesn't feel like a tie. Some providers are walking around telling people that they have a mild tie, or it's very posterior. And so, you can't quite feel it, but it's definitely restrictive. Based on what? Like, the structure is not even following your main flows of thought. You've got to have all three. So if you don't have all three, it's a problem. Already red flag, not a tongue tie. Like, do not pass go, do not collect $200. Okay. Symptoms. Symptoms, incredibly important. You'll hear various symptoms from various people in the other tongue tie is modern medical scam lecture. I go through a little bit more about the infants, because infants wind up being released more so than children and adults. And then children would be secondary and adults would be like the least amount of the population that are undergoing tongue tie releases. But infants wind up being the big ones. 34 to 96% of breastfeeding relationships start out with problems. A tongue tie in it, that's not the end all be all. It's not, oh my gosh, we can't breastfeed, and so the kid is 8 days old, let's go get it released. You got some functional work you can do. Not all of these symptoms have to be associated with dysfunction, or at least not dysfunction you're familiar with. Have you considered Have you asked enough questions? Have they ruled out other contributing factors? A tongue tie isn't the only thing that could be potentially correlated with poor breastfeeding, malocclusion, cranial facial suboptimal growth is what I want to call that, I guess. There could be other things and other factors at play. They could just have poor motor planning skills. It could be a gross motor skill problem that they need to have gross motor work done before you ever consider doing any fine motor work. It could be a global problem, even on a baby. Even on a baby. They might need to have PT or OT do some work on the baby. And maybe some of that, maybe the baby is tight in one chain. Like, how were they wrapped up in the womb? It might be that their body just needs to let go in some areas and they'll be fine. It could be your kid just has nasal obstruction, enlarged tonsillar tissues, and the lymph is not draining appropriately, and all of this is causing a issue that has nothing to do with the tongue. And if we address that first, then perhaps we won't need to do a whole tongue tie release. Could it be that they're just dysfunctional? There's people without a tie that just have no point of reference for some of the tongue range of motion movements. Do they have sensory processing issues? Are they orally defensive? Hyperactive gag reflex? And so most of the time they're not doing much movement at all. Parafunction? Have you ruled any of that out? If you didn't rule it out, you can't go off symptoms alone. And you really shouldn't go off of what it looks like alone, much less what it functions like alone. So you've got a whole lot of questions, okay? Because not every tongue that can't elevate is tied. Sometimes it's just undertrained, underused, obstructive, defensive, or compensating. That's okay. It is okay. Those are things we can work out in myofunctional therapy. So when you're looking at it, people sometimes are like, what am I even looking at? I think a lot of times people forget that we are mere humans. And so, yes, we do forget things. We forget a lot of things, right? A lot of times I'm on stages and I'm talking and I will mention that the tongue is a muscular hydrostat and how many tongues, how many tongues, that's funny, how many muscles help comprise the tongue. And people will be like, 4, 6, like professionals who definitely had craniofacial or head and neck anatomy in school, dental school, in hygiene school, whatever, and can't name all the muscles. It's okay. We're going to do a quick review because it's important that we are able to know what we're looking at. So when you are looking at a floor of the mouth, I was going to call it a sublingual space, and then I realized I'm doing too much. Floor of the mouth. When you look at a floor of the mouth, let's see if my cursor will work for me. Yes, it will. Yay. Our frenum is literally this little projection of tissue there. Sometimes people will elevate and you can't see anything. It just looks nice and smooth, right? I've had mentors tell me that that's ideal. If they could do that, awesome. That's the goal. Like, I don't think everybody's going to get there because you do have 2 points of attachment. You have your attachment site on the bottom and you have your attachment site on the ventral or the bottom of the tongue and the floor of the mouth. Okay. So you have that whole thing. That's the frenum. Okay. Sometimes people get really concerned when they see the little elevated spaces here. That's sublingual papilla there. There's also ducts there for the submandibular glands. And so sometimes those are just a little full. And so it looks inflamed. We also have sublingual glands on the floor in the back here. And so there's a lot to look at. Okay, a lot to look at. Most of the time you'll look under here and everything will look super duper normal as far as looking for oral deviations from normal when you're doing an intraoral exam and you're trying to determine oral cancer. Is there anything unusual? Or you're looking at trauma, or you might be seeing a trauma lesion and you're like, how do I know what's normal? This is pretty normal. Is the crowding normal? No. But we're not looking at the teeth, we're looking at soft tissue. So I need you to focus on the soft tissue in this image, okay? So when we're looking at, and everything that I will reference from here on out, when we're talking about tongue ties, because this is only about tongue ties, I'm not going to talk about buccal or buccal, whatever you call them, ties. I am not going to talk about labial ties or lip ties. We are just talking about tongue ties. When I'm referencing a tongue tie, it is this lingual frenum, okay, from here to here. This is what we're working with. This is what we're talking about today. It's nothing else. It's nothing else. Sometimes it can be wide. Sometimes it can be thin. Sometimes it can be almost webbed. So forget the fact that like the tissue itself might be wide. It can look like a broad web. It might look like the Eiffel Tower. There's a lot of things it could look like. Okay, this is our anatomy. When you're looking at the structure and you're trying to assess structure, because we talked about the symptoms. Now we're getting into the structure and we're going to dive into function next. Okay. When we get into the structure, there is no one identifying factor that can determine that a tie is a tie. No one. It's got to be a bunch of things that kind of come together. It could be that there is blanching in the tissue. And so blanching would look like in this. Is that going to? No, it's not. There we go. Here we go. It might look like this little string of tissue here. You see how white it's gotten? If you've ever taken an exercise band and it's just one of those green, red, black, they're different colors bands, and you stretch across like you're doing a isolated or like you're doing an exercise and you're just trying to hold in resistance, in isolated resistance, and you've got this band on and you look at the band, you might see little striations of white. It might look like it's starting to get a little discolored because you're pulling it beyond its normal capabilities, right? So as you're stretching it, it's losing some of its color. Our tissues do that same thing, loses just a little bit of its color. So when we're looking at blanching, we're looking at tissues that are very, very white because they've become so stretched. They really just lost a lot of color. That is a lot of elevation for that tongue that probably doesn't normally elevate, and therefore this is a very, very white or blanched frenum. Okay. It might have an Eiffel Tower appearance where it looks really broad at one end, and this isn't like a good one, but where it looks really broad at one end, like the Eiffel Tower, and it comes up into the attachment more narrowed than it is broad. So it's broad down at the floor of the mouth and more narrow at the top. It could be attached on the floor of the mouth, or it could be on the alveolar ridge, which is always an interesting place to find them. Okay. It could be clefted and have a deviation, like a little notch almost. There we go, a notch almost in elevation or in protrusion. You might extend the tongue. You're like, ooh, look at that. That's that frenum pulling back on the midline of the tongue. And so you get a little cleft, or it's pulling back here on the tongue tip, or what would be the tongue tip. And so you get a butterfly looking appearance, or a clefted elevation, or clefted extension. It could be where it is attached further back on the base or the underside of the tongue, the ventral surface of the tongue, which attached in the middle, where it's attached right at the tip. Could be any number of places. Okay. So when you're looking at structure, it's really a combination of all these things. Like, what are you seeing and how does it look? Function now is totally different. Function is an interesting approach because when you're looking at function, sometimes you look at function, you're like, oof, that is straightforward dysfunction. Like, this is a grown person with a tongue that in suction They've barely got 10 millimeters of an opening. And you're like, okay, we really got to talk because it doesn't look good structurally and you're not performing very well functionally. Now we got to talk about the symptoms and if there are any symptoms, because that's a big thing. It may come as a little bit of a shock or surprise to you, and I am very, very sad that my GIF isn't working. But okay, because I have a lot of these from this show. I love this show. Um, it might come as a surprise to you, but I don't use classification systems. A lot of times people come to me and they'll say, oh, somebody told me I have a class 4 or class 3 or class 2 or class 1. And I'm like, that's great. Wonderful. They looked at you from one perspective of function. Now let's really talk because I'm going to get deeper. I have more time to get deeper in my consults. I have more time to get deeper. Most myofunctional therapists do. If you're doing consults, you're sitting with people and talking to them in depth about their history, about their function, their oral function. You're looking at it from a variety of perspectives. You're seeing all of the tongue and facial and clavicular. You're seeing all of the compensations. You're seeing everything all at once. And so I don't use classification systems. Instead, I use terms that really will define what I'm seeing. So if it has clefted elevation and it is taught upon palpation and visually it is thick, broadly attached in the alveolar ridge, I'm using terms in a lot of my reports and how I am actually talking about a frenum that are a lot more descriptive to what I am seeing and how it all comes together, even to the point where I will say no functional restriction on lingual range of motion examination or evaluation. No functional restriction present, despite lingual frenum being taught, thin, some mild blanching on elevation, and I'm able to explain myself. So, yes, you might see those things. I want you to know I saw those things, but here's why it's not functionally restrictive, because I got such and such mobility out of it, or it's borderline. It's borderline. I don't know. It could be a tie, it might not be a tie. I don't use classification systems because, as far as I'm concerned, they don't tell you enough. They tell you one set of movements or elevation. You got the tongue tip to elevate. You got the tongue tip to your tongue. I'm sorry, to suction. If they could suction, more often than not, I'm meeting people who are being referred with tongue ties who cannot suction. And so it's like, well, how did you determine what else they were able to do? Did you ask them to retract their tongue? And did you ask them to lateralize it? What did the protrusion look like? Was there any clefting? Like, you telling me you saw a class 4 tells me nothing. I ask for so much information and I look for more information. So I don't use classifications because they don't tell me enough. And I think that that's a really important thing, because a lot of times less than 1% of dentistry is doing airway, period. A smaller percentage of that, even the people who are doing airway, they're not doing myofunctional therapy. So when you get somebody who is doing myofunctional therapy or who will refer to myofunctional therapy, I want to talk to them in terms that they would understand, and I don't want them to have to go and look up other things. I don't need you to look up what the classification system is that I used, or why I used it, or whatever. This is what I saw in the most plain of terms. There's some medical terminology or dental terminology in there, but outside of that, this is it. So you won't see me reference any sort of classification systems. It's just not in depth enough for me. That's me. Okay. However, you know, if it's very, very obvious, you've got the triad, just move forward. Move forward. I don't need a classification system. If my release provider wants to use one, yay, go you. I will happily support you and put what you need on this document. So sometimes they want an update after the class 3 release. What do I think, and how is it performing, and what's function looking like, and how's recovery, yada, yada, yada. Okay, if you want me to use that, I will use that, but I'm not going to reclassify them. I'm going to give you, these are my objective findings. Okay. So if it's obvious, move forward. Even when it's not obvious, you should probably move forward. Just move forward. Functional assessment. So, functional assessment is how I'm looking at function on a more dynamic level. I'm not looking at function from baseline, elevation, or suction. I'm looking at function from, is there a genetic component to this dysfunction? Is there some deficiencies here? Are they low muscle tone globally? And so, therefore, we've got some issues there that might be actually presenting our problem. Compensation patterns, what muscles are being involved in certain tasks that shouldn't be involved. I want to disassociate all of that. That way I can make sure that I can see very clearly what lingual function is in isolation. What's dysfunction like at rest? At rest, that's proper oral resting posture. Are they able to achieve proper oral resting posture? One thing I've never understood, and if you know it, understand it, and want to explain it to me in the comments, please do in the comments. But when we're measuring for tongue function, and we do the lingual palatal suction, so the tongue in suction, and we want that to be more than 50%. When at rest, we still want the tongue in suction, but the tongue in suction would be at significantly less. I mean, they're not even, the teeth are 2 to 3 millimeters apart at rest, ideally in freeway space, maybe even less than that. Even with that suction that I showed you before, they could suction with the mouth closed. I don't know. I never understood that. But if you get it, then let me know. But dysfunction at rest, where does the tongue rest? And is it capable of resting properly? Do they have the ability to access posterior tongue muscles? That's that interoception. That's, are you able to feel and assess some of those posterior muscles? Can you engage them? What's that mobility like? Are you hypermobile? Because then I want to be very, very aware of what I'm going to do, because we might not even get into like, oh, we need a release. Hypermobility, if your maximum opening is 68 millimeters, we're not trying to get you to have 34 millimeters of tongue to spot elevation. We're not looking for that, right? So if you're hypermobile, I'm looking for different sets of metrics, and that's also a whole nother lecture that you could watch later. Sensory processing issues are going to really absolutely impact the ability to feel and to be aware of what's going on. And then, is there structural support for proper function? If they have a narrow vaulted palate, why would we release a tongue? Where's it gonna go? It can't go up in the palate. So we might be needing to talk about, you're structurally incapable of having this function that you're trying to achieve with a tongue tie release. And so if there is a structural insufficiency, retrognathic mandible, narrow vaulted palate, they have physiological barriers to nasal breathing, red flag. Throw a whole flag on the play, because it is not going to be something that you're going to be able to work on by having a tongue tie release. So my functional metrics are much deeper than whatever measurements people are getting, because I need to know all of these things, right? And if so, if any of that is present, can you confidently answer, does this tie have the ability in persistence, its mere presence, to disable us from achieving improvements in compensatory elimination, achieving proper oral rest posture, decreasing some of the instabilities of hypermobility, increasing interoception and sensory processing, proprioception. Does the tie alone, being there physically, make this an issue? It's okay if your answer is, I don't know. That's okay. In all the mentorship that I do, and all the people I talk to, anybody who texts me questions, who emails me questions, who whatever, they're like, hey, I have somebody, I don't know if it's a tie, what do I do? They're confused. I don't want to sound like I don't know what I'm doing. You know exactly what you're doing. You just know that there's more to this than looking inside somebody's mouth, looking at a physical structure, determining that that is wrong, because that's all that is. That's wrong. You have a tie, it's wrong. Cut it, remove it. It's wild. Okay. You're a competent clinician who is able to now step back and say, look, we can move forward trying to nail these functional goals. If we meet these metrics, we're not going to revisit the idea at all of a surgical revision. However, if we cannot meet those metrics, we are hitting up against a wall, you know without a shadow of a doubt that that structure is functionally limiting. And if it is functionally limiting, then we're going to have to talk about sending you to such and such for release. And so these are the conversations we need to be having. These are the steps we need to be taking. These are the things we need to be saying. It's okay to not know. It is okay to not know. Information, all that information you just collected, all the information I collect, none of it's useful until it becomes knowledge. Knowledge, you don't know enough yet. You've collected a bunch of information. If you've collected data and taken measurements and looked at somebody's structure and you've heard their symptoms, that information is not useful until it becomes very clear to you as a point of knowledge that yes, this structural limitation will 100% stop us from being able to get any forward progress in function, in symptom resolution, and structural capability. Take your information. Feel free to take your time making it knowledgeable, because what ideally should happen with every tongue tie release, any tie at all, is that there should be a component of functional, your myofunctional therapist, your speech language pathologist, your occupational therapist, or your physical therapist, in conjunction with your manual therapy. Your manual therapy being your craniosacral therapist, your osteopathist. Oh my gosh, that's not a thing. Your osteopath, your osteopath, your chiropractor, your massage therapist who might be able to get in there and do a clinical orofacial massage. Shout out to Heidi. Then, once we've ruled out and topped off all of our functional and manual therapeutic abilities to help you rehabilitate, and it's been unsuccessful, structural release. If it's been successful, you knew that that was the problem all along. It had nothing to do with how the tissue was restrictive or short or tight. But if it is, structural release and then get right back into that functional and manual therapeutic work, because now you're going to get the progress that you weren't able to achieve before. So that knowledge comes through work. You have to work at it. Gotta work at it to make it happen. Okay. When I'm thinking about myofunctional therapy, tongue tie treatment planning, I like to think of it objectively, not subjectively, objectively. Okay. I want to establish, enhance, and as much as through and through as we could get, lingual proprioception. tongue tip awareness and establishment. Now, sometimes you can't always do that, like those butterfly or clefted elevations, protrusions, extensions, whatever you want to call them. Those clefted appearances, it's pulling so tightly that you can't really establish a tip, but you can work on proprioception and getting the tongue tip awareness kind of together, but you might not be able to establish that tongue tip until post-operatively. When the frenum attachment is a little further back on the base of the tongue, well, then you can establish a tongue tip, something that they more often than not don't do. They don't use that transverse. They don't like constrict the tongue and narrow it out enough to ever really have a tongue tip. And so it's establishing that. Lingual palatal suction and seal. You need to be able to suction, you need to be able to seal completely. It has to be fully connected. So not just a little bit of suction in the anterior, you should also get that seal in the middle and the posterior when you can. If you can't, it's part of your red flag. Okay. Lingual range maximization is really just hitting all of the functional range skills. You're going to be able to maximize how much elevation you can get, how much lateralization you can get, how much retraction you can get, how much posterior humping you can do. Notice cupping isn't here. I didn't pick cupping here on purpose because sometimes the cupping is something that comes after, so more post-operatively, but more often than not, if I'm isolating just tongue tie release, I don't get into lingual cupping. Lingual isolation needs to happen pre-habilitatively because I need to establish the tongue as its own independent thing. The tongue needs to be separate from mandible in movements and cervical muscular movements, more often than not, mostly the platysma. But you don't want to get too much of the extra bodies of the mylohyoid or the digastric involved in like unnecessary movement either. So you want to make sure objectively you're hitting these metrics and constantly reviewing. If you can't hit a metric, ooh, I can't hit 3 out of these 5 metrics, ooh, all right, we're going back and we're definitely going to start preparing for tongue tie release, because what we've got to do is make sure that we are able to check off a certain list of things, a little question list that we can answer definitively. Some of it has to do with, being able to know who you're going to send to for release. But the release is really just an opportunity for us to get back into that function and maximize. Okay. So you want to have all that. Our stretching and manual therapy. Now, this video, I have multiple videos, but this, I only put one in here because this video is not graphic at all. I'm just giving you that heads up because I know some of you who may have seen my other lectures, you might be thinking this is a video that it's not. So not graphic at all. This is how I like to do tongue stretch elevation. And I'll talk to you about it after the video plays. So let's see if it'll play on its own. And if not, I have to press this little button. Manual frenum stretch. The child opens or adult and then lifts the tongue up. There we go. You're going to see the top of the frenum, and you're going to place the sponge right at the top of the frenum, and then you're going to lift. Don't worry, I'll get a better angle. That should create, lift up and back. That should create some blanching or whiteness of the frenum that you'll see. And it's a 5-second hold. So you just count 1, 2, 3, 4, 5. She's not the best example person. She's very dramatic. And so I did her hair the other day, and like, you wouldn't have wanted to be here while I did her hair. It's like, she's the queen of drama. But we filmed this little video to kind of go along with a bunch of my homework sheets and other videos. But these videos I think are really helpful. The sponge, oral sponge swab that I use because it's just a little bit more friendly. You get the whole grip of your hand and you get a lot more force than you would get from two fingers alone. Two fingers alone, push something with two fingers, and then I want you to push something with the entirety of the force of your fist. And you'll see that, yes. So the sponge is lighter, like it feels softer. And a lot of my release providers are like, oh no, don't use that sponge. I know Keep Carice tells you use the sponge. Don't use that sponge. You got to get in there with your hands. You got to feel it. I'm telling you, if you do it, you will feel it. Okay. You get the sponge, you push, and you can put things on this. So when we talk about post-operative stuff, like when we talk about arnica or whatever else you're putting on, some people use coconut oil, whatever, you can get into the wound and really like get a good grip and hold. But practicing pre-operatively, it's really, really good. So you're less likely to get some of that traumatic lesion forming. Like people get in there and they start doing all this rubbing and they start moving their fingers all around in there. And a lot of that I feel is truly unnecessary. Now, this whole field is based upon being a bunch of our clinical experiences. So you could come at me if you want, but I'm not going to feel any kind of way, nor will I change my tactics because you don't agree with them. But I will say that a lot of that is very unnecessary, that you can really get a lot done if you just use the force of your actual fist to lift and to hold and to create that tension that would be needed to really elongate the wound and to sometimes get in there if you're trying to do a less invasive, less damaging application of something. You could use these. These are really cheap. You know, $25 will get you 250, or on Amazon, or you can even like do less than 250. You can get a box of 50 for like less than $10. It's completely negligible. But if you're going to use it for weeks, 100% Amazon, you can get 250 of these and like go at it, go ham, a new one every single time. Okay. What we're really preventing and trying to work against is the wound contraction that is chronically happening. Now, this was supposed to be a GIF. I'm not sure why it's not GIFing because it's supposed to be that muscle contraction, but we're not actually looking at muscle contraction, honestly. It's really fibrous contraction because what's really happening is it's a physiological process where the body, there's a wound, and you can imagine if you've ever had like a cut on your hand, we're not comprised of all our cuts and so forth. What the body is trying to do, I'm sorry, is primary healing. It's trying to put the pieces of the skin together, and therefore we're minimizing any sort of additional scar tissue and so forth. But if you were to allow the body to do what it wants to do, all of those microfibroblasts that are trying to put the wound together are closing up a space between the floor of the mouth and the base of the tongue. And so the easiest way to close that space is down on each other. And if you close it down on each other, what does that do for your tongue mobility? You have none, right? So we're keeping it so that it heals along the long axis of the wound. A lot of adults and more children now are getting the sutures, and so the sutures are doing that initial like wound healing along the long axis and keeping it closed up so that we can minimize the scar tissue. But you still have contractions. Like a lot of people feel like it's so tight, it's so tight. It's going to feel tight. Your wound is contracting even on the inside. The sutures are for the most external or superficial part of the wound there. And so what you're looking at is just one piece where there's deeper contraction happening. And so that contraction is what we're fighting against when we're doing all of our active wound management, or what I like to call optimal recovery management. So ORM. So, whatever. I'm a weirdo, just ignore me. It's comprised of stretches. I have floor of mouth stretches. I have frenum stretches. And that something was not supposed to be. That's funny. I have floor of mouth stretches, frenum stretches, and I have, extra oral stretches. So we're going extra oral too. So we have those stretches to really take some of what we're doing and help loosen it up in conjunction with, never in replace of, manual therapy. Always send to our manual therapist. Our exercises are really going to help us with reaffirming for the body. We're given that muscle memory. The tongue can work by itself. The tongue can work in isolation. And we're stretching the wound along the lung axis. Okay. So we're fighting against a lot of that contraction. The more frequently you're moving, the better off you are. And management is really a part of it too. You can eat, you can drink, have at it. You're not going to avoid eating or drinking. This isn't something where you get your tongue tie release and then, like, don't eat or drink. You can absolutely avoid anything too spicy, anything acidic, and anything with seeds. You don't want poppy seeds in your open wound. You don't want poppy seeds like getting stuck in between suture areas if it's not like very tightly sutured. You don't want poppy seeds within your tongue. Avoid your everything bagel for a few days. You'll be fine. Okay. Cryotherapy, ice, making sure you keep it cold. I tell everybody, stock up on all the cold things you could possibly stock up on pre-release. If you're stocking up on cold things pre-release, you are going to feel better post-release. You will have all your smoothies, all your ice cream. A lot of times for kids, that makes all the difference. I've had two of my children that needed tongue tie releases, have tongue tie releases done. And those two, well, one of them only remembers like, oh man, I got to eat Italian ices for like breakfast every single day for like a week. That's what she remembers. So it can be a really negative experience or it can be super duper positive. And we were like very, very crunchy in that moment in time in our life. So the fact that she had Italian ices was like, oh, and like the other kids didn't get them. What? Super special. So yeah, cryotherapy, really, really helpful. It's something cold. It just helps as everything feels so tight and inflamed and yucky, to just have something sweet and cold to help. There's prescription methods, ibuprofen or acetaminophen. Ibuprofen, really more so, that's like your Motrin, as opposed to like Advil or Tylenol, which would be your acetaminophen. Those are really helpful. Chlorhexidine sometimes is given as like a rinse sometimes. That helps just keep everything clean, and occasionally it might just minimize the risk of bacterial infections, although that's typically pretty low anyway. Revitaderm, that's a wound care gel that is over the counter, so it's not a prescription per se, but it's antimicrobial and it does help keep everything moist and more lubricated so that you don't feel a lot more of the contraction. So that contraction is something that is happening and that will continue to occur, but it is not something that is happening on the same level when you keep everything moist. So we want to keep everything nice and moist. Holistic methods of support: arnica, St. John's wort. St. John's wort, a lot of people ask about that, like why are we using that? It's from a particular type of flower, but it's homeopathic in nature, and that is going to help target some of those nerve tissues. That way, any of the sharper pains that you might be feeling, particularly day 1 through 3, I said the first 72 hours are a nightmare. That is going to be really, really helpful. A little bit of it as like a dropper. A little bit of it as a dropper is super helpful. Rescue Remedy is also a dropper that helps to calm the nervous system. So sometimes there are pictures on my Instagram, not pictures, but reels on my Instagram when my youngest had her tongue tie release and how she was just like so distraught every single time. Rescue Remedy helps a little bit before, so that some of that anxiety about we're about to do another stretch, I'm not ready, like it can kind of calm down. Clove oil, which you should never use directly 100% by itself. You do not want to do that. It is going to cause like a chemical burn, like a really sharp burn in the soft tissue. So clove oil, 1 drop mixed with like maybe a teaspoon of olive oil, and then take that, put it on your sponge. Uh, Really, really actually helpful. It does help to support some of that post-operative recovery, keeping everything nice and moist and so forth. In addition, coconut oil. I like coconut oil as well. And then being in collaboration. If you're going to be in collaboration, I would say 100% you want to be in collaboration with serapeptase, which we're going to talk about in just a second. But definitely Kenalog injections are something that would have to be done by the release provider. And so Kenalog injections are going to help to prevent some of the tightening of that tissue. So some of the more fibrous wound healing, we want to dissipate a lot of that, disrupt that for sure. And so Catalog would come along at that point, but that is something that is the release provider is not like a patient led thing. Let's talk serapeptase real quick. Serapeptase is like an enzyme, is like the easiest way for me to describe it. It was the easiest way for me to understand it. And anytime I'm explaining it, I'm like, it's like an enzyme. Okay. That's what it is. It's like an enzyme. But even more so than being like an enzyme, it's a very selective one. Okay. Now, this is something that was used a lot in oral maxillofacial surgery. And because it's so effective with third molar extractions and all of the research done around third molar extractions in dentistry, and this is something that you would get as like an over-the-counter, thing. It's been approved by the FDA. It is something that you could just buy, but you want to make sure that your serapeptase, okay, when you're using it the right way. It's really going to help to promote anti-inflammatory action over a 5 to 7 day period. You're not doing this for perpetuity. It is not something that's going to be in the long run. It's typically like 4 to 5 days after. But what this is doing is that it's going to selectively really like Pac-Man. So Pac-Man, let's talk about Pac-Man for a second. Pac-Man will go along and he's eating all these little dots, right? And he doesn't touch the walls. He eats the dots, he eats the ghosts. That's it. He does not eat the walls of the system. He doesn't eat anything extra. And if he does, it's bad, right? So what serapeptase is it's kind of like Pac-Man. It's like a selective little Pac-Man, and it's going to get all of the excess fibrin and that fibrous scar tissue, all those proteins, and it's going to start to digest them, break them down, and avoid all of the healthy tissue. So the healthy tissue just sits along and is totally fine. The serapeptase is attacking all the stuff that we don't want to stick around. So it's going to help to kind of soften up the wound bed. And that's really helpful for our myo because as it softens that up, and our manual therapist is also softening that up, they can now be more effective with what they want to achieve as far as now our range of motion, right? Typically, more often than not, it's recommended to start on day 4 or 5. So after that first 72-hour nightmare, I never downplay it. The first 72 hours, a lot of inflammation. Like once, sutures have started dissolving and so forth, like now this is when you want to introduce that. So you get a small portion of it, about a quarter of a capsule, and definitely it has to be without any fillers, and it would be applied under the tongue. Allow it to dissolve for 3 minutes. And you're working with stretching too while you're doing it, so it's doing its thing, eating up all those fibers, scar tissue, proteins, and then we're going to be able to maximize what we can do with myofunctional therapy. Is this every case? No, it's not kids. It's definitely not babies. 100% it's not babies. It's mostly adults that you would use a serapeptase thing. Now you're going to notice that post-operatively, functional planning looks very similar. Within 24 hours, I see everybody post-operative review, tongue tip awareness and establishment. They're getting their tongue to seal. Range is being maximized, all those same metrics. And then we can resume traditional myofunctional therapy once we've established lingual isolation rehabilitatively. So we are now in a space that is very similar. You're essentially just going back through objectively the same things that you were trying to achieve as goals pre-op, and now see if you can get them done post-operatively. Okay. I don't know if you could hear that thunder, but I'm going to have to end really quick. So sometimes the unexpected happens. People get really poor wound healing. It happens a lot. People do not expect the full scope of what they're experiencing. The first 72 hours might be very shocking to the system. They don't push themselves to move and maximize the range in the way that they should. And so you're just reviewing and demonstrating proper exercises, stretches, recommendations, or I like to just get in there, stretch it out for them. Like, I'm demonstrating, like, this is where we should be at. Are you uncomfortable? Yes, I know you're uncomfortable. I'm sorry, but this is how I need you to feel every time you do it. You're like, oh, all right, I get it. I understand. I know the difference. And a lot of times they tell me that they feel better after they do it, because while everything's trying to contract, we're fighting against it. So while I'm giving you those stretches, those exercises, those movements, the ability to do the releases, you are feeling looser. And that looseness, the natural hyaluronic acid that becomes produced as you're doing more mobility, it really does help. Oral aversion sometimes happens pediatric wise. For the pediatric cases, you want to avoid aggressive or firm stretching. Entirely refer out. Sometimes it's collaborative referral. They'll be like, oh no, they just need to work with us for a little bit and then they'll come right back to you. Sometimes it's just like, no, these are long-term plans to work on this oral aversion. And so you're going to need to actually like work with a provider. Nerve damage is next. Any sort of burning mouth, altered taste, prolonged numbness. It could be minor neuropathy that may resolve. It could resolve itself within 8 to 12 weeks. Beyond 4 to 6 months, it's probably a nerve that's been severed or is severely damaged. Photobiomodulation might be helpful, but you're going to collaborate with a release provider and an oral maxillofacial surgeon, because sometimes they might be able to do a surgical procedure that might help to restore some nerve function. Okay. Neil. Neil has said that rejecting what someone outright says is as intellectually lazy. And we're not intellectually lazy because we're all professionals. If you're watching this, you're a professional. Is as intellectually lazy as it is to accept what they outright say. And so you don't want to reject something that you hear right away, and you don't want to accept something that you hear right away. What you want to do is you want to line up a series of questions, probe and explore the thoughts of that person, and so push back against a little of this. If it's so vastly different from what you do and you have like a structural program and you have something that you're really like, this is it, push back against me. That's fine. I don't care. If you are working with somebody and they have a certain protocol, I push back against providers all the time. I'll ask questions. Why? Why are you doing this a certain way? They might have something that you could learn from. There might be an opportunity there to have a deeper talk about what dysfunction looks like versus what you think it looks like as the functional specialist in the situation. And so 100% never just accept everything that you hear or reject it right away. Push back and formulate your own opinion based on their thoughts. I think that makes sense. But there's also just objective questions that you want to make sure that you can answer and that you should answer, because the goal is not necessarily to get a beautiful before and after picture or to get the lottery winning outcome of like, oh, I got the release and instantly all of my pressure was all gone and no more neck tension and my back feels free and yay, I sleep better. These are never the goal. The goal is to always improve upon the function, the structure, the symptoms. And so you want to be asking questions. Make sure you're looking at everything with a more thorough lens. That way, you're able to make an educated assessment. I don't believe in myofunctional therapists that are not able to therapeutically assess. If it has to be some simple, like we did a measurement and this measurement didn't work, and so therefore it is a tie, you're not a therapist. You did, you're a mathematician, you did an equation, and yay, you've resolved one metric. But being a therapist really requires that you are looking at things from a more dynamic lens and approach. So put it all together, put all the pieces together. I invite all of your questions all the time. And I would say, even more so, I invite you to really watch this other lecture, because this is probably going to be where everything happens and where you learn the most. I'm so happy to have been here with you today. I look forward to seeing you at the next one, where we're probably going to do a little experiment with AI and see how well AI can duplicate myofunctional therapy. Until next time, friends, bye.